Good afternoon, everyone, and thank you for taking part in this great progress report. I would like to walk you on a journey through my PhD research, which focuses on novel neurosurgical interventions for patients with drug-resistant epilepsy. My name is Arashk Zabihi, and as a neurosurgeon resident, I am interested to advance the field of minimally invasive neurosurgical field. My vision is to improve the quality of life for patients living with drug-resistant epilepsy. And given this vision, I started my PhD journey to bridge the research and the clinical practice. And my mission is to investigate novel, minimally invasive neurosurgical intervention, which provides a better outcome with an ultimate result of the improvement in a standard of care of patients. Okay, so about our specific goals. Currently, we have 2 projects ongoing. Our first project is about investigating the safety and efficacy of a rare disease, a congenital disease, with minimally invasive interventions, this disease is often related and associated with drug resistance. While in our second project, we are also investigating the same 2 interventions, but the population is different. Actually, this is the most prevalent population, the mesial temporal lobe epilepsy, which is the most prevalent in focal epilepsy. Okay, let's go to the first meta-analysis, which focuses on investigating on safety and efficacy of minimally invasive neurosurgical intervention in patients with periventricular nodular heterotopia-related drug-resistant epilepsy. About the background, okay, epilepsy is a global challenge. More than 15 million people are affected by this disease, and this contributes to a lifelong disability, to social burden, to economic burden, and also an increased risk of premature death. Periventricular nodular heterotopia accounts only approximately 1 to 3% of epilepsy, but it's important because nobody is really interested in this disease, so we can find only just a couple of articles. And oftentimes, it cannot be treated by anti-epileptic medication because it's drug resistant. However, 60 to 80% of the patients can become seizure-free if they are getting the surgical intervention, which is new. They just came up a couple of years ago. The gold standard was the open surgery, which today is not practiced anymore because of the deep-seated nature of the disease. As you can see on the picture, it would cause damage in the eloquent brain region. So the novel interventions are the Stereo-EEG-guided radiofrequency thermocoagulation, and the other one is the MRi-guided laser interstitial thermal therapy. And the critical problem here is that in the literature we cannot find a consensus about the optical surgical approach. So our aim is to compare the safety and efficacy of these 2 minimal interventions in patients with periventricular nodular heterotopia-related drug-resistant epilepsy. And our main clinical question seeks to find out whether the MRi-guided stereotactic laser interstitial thermal therapy provides a better outcome compared to the Stereo-EEG-guided radiofrequency thermal coagulation in these patients. So actually, we are comparing these two interventions, and we would like to find out whether the seizure reduction is better in one of these two cases. And as a secondary outcome, we are also interested in cognitive impairments, as, for example, memory, or visual field impairments, or motor skills, or speech. The hypothesis is that the MRI-guided intervention provides a better outcome compared to the RFC-guided intervention in managing the drug-resistant epilepsy in these patients. And the clinical implication is seizure control or completely seizure freedom life. Okay. We conducted a systematic search with the following search key in 3 major databases, the PubMed, Embase, and Scopus. And here is our flowchart selection. We found more than 400 articles. After the duplicate removal, we ended up with 258. And together with my selection pair, Tamás Óváry and Muskan Ashwati, we already did the selection based on title and abstract, and we ended up with 26 articles. Okay. About the progress, we submitted the Prospero in the beginning of November. It was accepted like 3 weeks later. And right now we are in the phase of reading the full text. Let's take a look about our second project, which is about investigating minimally invasive neurosurgical outcomes in patients with mesial temporal lobe epilepsy. We are still talking about epilepsy, but in this case, the mesial temporal lobe epilepsy is the most frequent one, affecting more than 13 million people worldwide. This can be treated medically. Approximately 65% of people can reach seizure freedom life, but more than 10 million people are suffering from the drug-resistant consequences, which also drives to the lifelong disability and loss of economic care, social burdens, and an increased risk of premature dying. Okay. The biggest problem here is that the temporal lobe encompasses vital parts of the brain, like the hippocampus and amygdala, which are important for memory formation, for learning, for emotional regulation, for spatial regulation, and neuroplasticity. So a classical open surgery has a lot of side effects. And the gold standard intervention was the anterior temporal lobe lobectomy and the amygdalohypectomy. But right now, I'm interested in these minimally invasive interventions, the MRI one and the EEG one I already mentioned before. So the aim is to compare the cognitive outcome of these two interventions and to determine which approach is more effective. Okay, the clinical question relies on comparing these two interventions, and the outcome here is exchange. So our first primary outcome is the cognitive outcome measured on Wechsler Memory Scale, California Verbal Learning Test, and others. And our secondary outcome is the seizure freedomness. And our hypothesis is that the MRI-guided intervention is much better than the CEG one. Okay, the clinical implication is a life with less neurocognitive complications. We conducted a preliminary research. All the key articles were found, and this was, right now we are here, and the summary, in summary, okay. So I would like to end up with this project that are both of them are important parts of my PhD research, because I'm aiming critical parts where there are missing information that can be used in every day in the clinical life. And I would like to translate these firstly, I would like to write these reviews and meta-analysis and provide a high standard evidence which can be translated in the everyday life. And with this, I would like to thank you for your kind attention and leave you with one of my favorite quote, which says that you cannot ever reach perfection, but you can believe in an asymptote to what you are ceaselessly striving. And I think that even right now, we still have room for improvement. Thank you.
Excellent. Thank you very much. So last options for time for questions, please. The right side.
I was faster, sorry. Yeah. So congratulations on your presentation. Your topic is really interesting and impressive. And actually I have two questions regarding your first project. Yeah. The first one is that you are comparing two minimally invasive interventions. Why do you presume that the MRgLITT has better or will have better outcomes?
Mm-hmm. That's a good question. Can we go back to the slide a little bit? Thank you. So here is a picture about, okay, I don't know how to use it. Doesn't matter. Here is a picture, and we can see that the intervention differs in the number of the entrance, because in the EEG gun we use a lot of electrodes, like 10, 15 to 20 electrodes. That's a lot of actually wound on the scalp, while the thermocoagulation uses only one. And it can be in real time. You can see the heat, so it is measured, and you can just stop whenever you see that the heat is too high, or if it's not too high, it's not high enough, you can set it up in real time. While in the CEG one, it's better for a diagnostic process when you don't know where is the focal point. But it really depends on the disease. So there are some diseases where the CEG one is better. But right now, I think that the MRI will be superior.
Okay, thank you. And do you expect to be differences in complication rates between the two arms?
Yes, given the information I mentioned before. I think, for example, the infection rate could be higher in the CEG1 because they have more wound, for example. And also it can damage some eloquent tracts in the brain using like 15 electrodes. It's 15 times more than one.
And does the learning curve affect it somehow?
About the learning curve?
Because you have to.
Well, surgery is affected about learning curve, yes. And I don't think this will be a bias in this meta-analysis because, as I have read the articles, they are publicating from the same centers. So I can see the publication from 2010 till 2024 from the same 4 or 5 centers. So even if in 2010 they didn't know how to do it perfectly, I think in 15 years they are on their peak.
Yeah, maybe. Okay, thank you so much.
Just a fast yes or no question from here on the left side. A surgical technique question. Do you use robot arm guide or just manual manipulation with the stereoscope?
In this way?
Yes.
We use a frame around the brain.
Yes.
And that one can be actually associated with the MRI picture. And you know exactly where you are manipulating. So.
But you're still with your hand, so it's not, the guide isn't held, for example, with
You are putting it with your hand, but anyone could do that.
Oh, okay.
So actually,
but then,
because I'm telling this because it stops right when you are at the right point. So it feels how many millimeters or centimeters you are in, and it just closes the entrance. You cannot go deeper.
Because I saw many functional brain surgeries with the ROSA. So do you see the use of that arm?
Yes, actually there are articles with ROSA.
Okay.
So that's right.
So we don't need a brain surgeon after all. So we
hopefully.
Hopefully you are working for this.
I'm working for minimizing the damage because
I think that's a better answer.
these two interventions are less minimal than just cutting off the half a brain. So lobectomy is the past, hopefully.